With proper instruction and coaching, almost all patients can perform spirometry that is acceptable and repeatable. The causes of failed test performances can usually be identified. Then, with re-instruction and good patient-technologist interaction, they can be corrected. We'll look at some of the errors that lead to failed spirometry testing sessions. Skilled technologists should be familiar with each of these common errors and be able to take necessary steps to correct them. Poor posture, such as slouching or leaning forward excessively, can cause early termination of the test. Instruct the patient to sit up straight, look forward, and keep both feet on the floor. The patient lowering his or her head can cause glottic closure or also early termination. Remind the patient that the head should be slightly elevated, the chin pointed forward. Volume is compromised when a patient doesn't establish and maintain a good seal around the mouthpiece, resulting in a decreased forced vital capacity due only to technique. Have the patient seal his or her lips tightly around the mouthpiece and maintain that tight seal until he or she has completed the maneuver. Improper placement of the mouthpiece in relation to the patient's tongue can cause poor test results. The patient should keep his or her tongue under the mouthpiece at all times. Also, make sure that the patient is not wearing dentures or other orthodontic devices, as they can potentially block the mouthpiece, therein negatively impacting test results. Air can escape during expiration if the patient is allowed to breathe through his or her nose. The absence of nose clips during testing also allows the patient to take a double breath. Nose clips should be worn during every test trial. The patient may not breathe in deeply prior to the forced expiration, causing a decreased forced vital capacity. One way to identify this problem is to compare the volume of air expired and the volume of air inspired. They should be similar. The graph here illustrates a test where the patient inspired a larger volume than he or she expired. To correct this error, coach the patient on the importance of filling his or her lungs completely just before the expiration. This is a very common error, and careful attention must be paid to achieving a complete breath in prior to forced expiration. Back extrapolation and hesitation may prevent the patient from meeting start of test criteria. Have the patient avoid hesitation directly before the forced expiration, telling him or her to blow out fast after breathing in deeply. Forced vital capacity may be overreported if the patient begins to expire forcefully, stops briefly and inspires, then continues with expiration. Once the patient begins the expiration portion of a test maneuver, he or she should not stop breathing out until the maneuver has been completed. Coughing during expiration and other uneven efforts is unacceptable. If the patient coughs during the first second of expiration or puts forth an uneven effort during expiration, have him or her repeat the trial. There should be no coughing during the first second of expiration, and the graph should exhibit a smooth and continuous curve. A maneuver is not acceptable if end of test criteria are not met. The patient may achieve end-of-test criteria by re-instructing him or her to blow out for at least 6 seconds and achieve a 1-second plateau. Observe the volume time curve, which illustrates a 6-second expiration time and a 1-second plateau. The patient may exhale for 6 seconds, or 3 seconds if the patient is 10 years of age or younger, yet fail to achieve a minimum 1-second plateau, resulting in an unacceptable volume time curve. Make sure the patient continues expiration until there is no air left. A flow volume loop may also be unacceptable if there is poor inspiratory effort following forced expiration. Re-instruct the patient on the need to take a deep breath in to total lung capacity directly after having forced all the air out of his or her lungs. A note regarding poor effort. If the patient appears to be providing good effort, a decreased inspired flow may be due to pathology. A thorough understanding of acceptability criteria simplifies the error recognition and correction process. The technologist should ask each of these questions at the end of every spirometry test maneuver. We'll go over them once more. Did the patient understand the instructions? Was the start of test satisfactory? Was inspiration performed with maximum effort? Was there no glottic closure, mouthpiece obstruction, or leakage? Do the results show an obvious 1-second plateau? Was the expiration time 6 seconds or more, or for children 10 years of age or younger, was there an expiration time of 3 seconds or more? Was expiration smooth and continuous? Was the effort maximal on expiration? Also, check acceptable trials for repeatability. The two largest forced vital capacity values should agree within 150 milliliters. The two largest forced expiratory volume at the end of 1 second should agree within 150 milliliters.